Today I'm feeling a little starstruck by this next guest. And by the end of this interview, I think he's going to knock your socks off too. This is Dr. Nathan Goodyear. He's a medical doctor, OB gynecologist, conventionally trained, but at some point he took a fork in a road. He realized a problem, lots of problems, as you'll find out, within the world of medicine, and has dedicated his career and his life to integrative, cutting edge, pioneering solutions for cancer care and solving some of the most intractable, dangerous, and scary diagnoses that exist. Everybody knows somebody who's had cancer, and getting that diagnosis and the confusion and going through the conventional system. The war on cancer was declared by President Nixon 50 years ago, and the war's not over. In fact, I would say that, and Dr. Goodyear will correct me if I'm wrong, that we've barely made much progress overall. Maybe some cancer survival rates have increased, but the paradigm has not shifted in a fundamental way in that 50 years. So we're going to dive into all of that to educate you, teach you what you can do, questions you can ask, and how you can start to access the care that can really make a difference in you or your loved ones' lives. So, Dr. Goodyear, if I can call you Nathan, welcome to the Delivering Health podcast.
Well, John, thank you. And I don't look at, I appreciate that introduction, but I look at myself as just a doctor trying to help patients. And where something is working, okay, let's dive into that. Where something's not working, let's figure out why and let's pivot. And so, my career, coming out of that OBGYN world primarily as a pelvic floor surgeon, what I found very quickly is we can help some patients, but I found out we by no means could help all patients. And so that's what really began my, as you mentioned, the fork in the road movement. But it's been one that as you start turning a page, you start going, and basically, in medicine, what we've not done today is fuel that curiosity of mind, which fuels innovation. We've stifled that, and we've created conformity of thought. Part of that's driven by regulation. And so what happens is, patients aren't being helped, yet the platform of cancer care, because that's where I work primarily, but understand that ripples out to all disease and prevention, that it perpetuates a system that drives profits. Yeah, it can help patients, but basically it's moved a patient, not just from an individual with a problem, but to an individual that's chronically sick, that is the linchpin in the system, and it's the means to profit and the means to keep them sick. So, for me, it's about changing the system and restoring its purpose, which is, as I always say, we're healers that teach. We're teachers that heal. So let's get back to that purpose.
And when you look at this from a systems perspective, there's a financial incentives. There's also legal and regulatory incentives for not making radical changes or for not even pursuing certain clinical trial avenues because perhaps a natural product cannot be patented. Right. And that's where the financial incentives come from, and then claims that could be made. What you've done with some of your work is look at existing treatments, but also other therapeutics, natural off-label prescriptions, other modalities and ways of approaching this instead of what I call a basic like napalm kind of approach of chemotherapy and radiation and just trying to kill everything. So talk about how, that conventional approach is still, and how you think we could be moving, or it could be moving in a direction that better serves the patient in terms of survival and outcomes.
Yeah, I mean, we see this throughout everything. You talked about the war on cancer, and I talk about that a lot, John, because I think it really gives perspective to where we've been the last 75 years. And I think it's a good launching pad to your question. because Nixon declared war on cancer via presidential address in 1971. Of course, Congress didn't do that, but Nixon declared it. Yes, it was symbolic. However, it was to drive, it was to drive investments. It was to drive a focus. And so I think it was initially with good intent, but you have to actually go back even a little bit further into history, because when you look at, for example, I call them the unholy trinity: chemotherapy, surgery, and radiation, because yes, they kill rapidly dividing cells, but oh my goodness, do they not destroy the immune system and cause off-target toxicities. So, when you go back to chemotherapy, because I think it's kind of that front and center icon there in that unholy trinity, it was literally born out of war. I mean, literally, where it actually went back to Paul Ehrlich looking at treatment of one disease with one chemical. And then there was some in World War I looking to bring that chemical concept from the disease standpoint, the magic bullet theory, to actually bring it to the battlefield. And so they actually started using these chemicals in the battlefield. In fact, one of the individuals that did that, he was called Dr. Death. His wife committed suicide. And in her suicide note, she basically touched on the point of what he did and how that basically impacted her. So people don't talk about this. That then transferred into World War II and what's called Little Pearl Harbor. Everybody knows Big Pearl Harbor, right, in Hawaii, but this was in Bari, Italy, where the Allied forces were actually moving chemicals because they thought the Nazis were going to use chemical, even though neither side was supposed to be doing that. The Nazis bombed it, and what we had is all this release of Agent Orange and other agents. And what happened is a lot of people got immunosuppression, suppressed white blood cells. But then the military started investigating this and going, what's going on here? Then there was a colonel that took interest in it by the name of Dusty Rhodes, and he goes, you know what? This is very interesting. And so in that standpoint, obviously there was interest in leukemias and lymphomas. And so he then worked with others by the name of Sloan and Kettering. And they came together and said, this is interesting because we could actually use these agents to basically suppress the immune cells that are involved with things like leukemia and lymphoma. So it makes sense. But when we look at chemotherapy and we're shocked by the damage that it does, we shouldn't be. Where has war done anything but create damage? And people will say, well, it's off-target toxicity, it's collateral damage. I'm sorry. In war, there's only damage. It's intended and it's unintended. And what we get in cancer is intended and a lot of unintended. And so what we have to do is recognize what the last 50 to 75 years has brought in the war on cancer and go, where has war ever benefited the populace? And that's why you see this war industrial complex being so hard to break that out of the mindset, because basically the medical industrial complex is just a different side of the same coin of that war industrial complex. What we need to do and what the science is telling us today, John, is enough war. We need to target the tumor precisely. We need to target immune activation, because all chemotherapy does, all surgery does, all radiation do is they damage the immune system. We must pivot because the science demands it. More so, the patients and their healing capacity demand it.
And before we get into how you do that and the incredible work and research that you're doing that you shared with me previously, I do want to understand for my own knowledge as well that there is an increase in the number of cancer survivors. More people are surviving cancer, and I'm wondering, is that because they're just simply more people with cancer, and therefore you're just going to get more survivors? Is it per capita survivorship is going up? And my understanding also is that the reason why, at least one of the main drivers of increased survivorship, is earlier detection, not necessarily changes in therapies. Do I have all that? Is that correct?
Well, I think there's a lot of truth in that. I was really quick looking for an article that I was working on, but I couldn't find it. So I'll try to remember it correctly, and then I'll post it as a blog post. But what we're dealing with cancer today, John, is different than the cancer of yesterday. And because when we look at the cancers of yesterday, where cancer is a disease of the aged, primarily there we look at, the 60s and 70s and 80s. And that has been true, but the actual understanding is now that it's not actually that it's old people, quote unquote, but it's that it's the aged cells. And so where we're seeing stabilization, where we're seeing even some reduction in the incidence of cancers and extensions of life in cancer, it's in that cancer of the old, the older cancer type. What we're seeing right now is a pivot to a new type of cancer. And of course, that pandemic was really a massive pivot point, though I think it even was predating that. And I think you could loosely categorize them in the understanding of obesity-related cancers. These are very different cancers. And what we're seeing is increasing diagnosis, incidence, and mortality associated with these newer types of cancer, because these newer types of cancer are really an accumulation of toxins and toxicants and dysfunction that are accelerating from generation to generation. And these are what are manifesting the pivot from a disease of the older 6th, 7th, 8th decade to those in their 20s, 30s, that it boggles the mind, because now we understand what's manifesting is the accumulation of this dysfunction, these disease toxicants. And that's not a political statement, by the way. Processed, ultra-processed food, overuse of antibiotics, absolute destruction of the gut microbiome, and destruction of immune priming in children, is we now have the basically the pulling the screen or pulling the curtain back on the aged cell. It's age of the immune system, and this is disabling the immune system to pervade the landscape of the body and survey for abnormal cells and then tag them for destruction, and in turn allowing them to perpetuate, grow, create more aged cells, what are called senescent cells, that then propagates disease. But it's not just cancer. It's basically all disease. So we're really dealing with a new type of cancer.
And so when you look through that lens at cancer development and propagation, how important then are the genetic fingerprints of the different cancers, because that's driving a lot of chemotherapy decisions these days. I'm wondering how that fits into this new understanding of the cancer phenotype and cancer cells.
Yeah, that cancer as a genetic statement was basically what I was taught in medical school from 1996 to 2000. And now we know less and less and less and less of cancer is what's called germline genetic mutations. That's where you inherit it. Okay, obviously there's still BRCA1, BRCA2, and others that are a part of that. But it's currently estimated that 5 to 8% of cancers are genetic. So I think that's even going lower. What we're here talking about is more of what's called somatic gene mutation, which is mutations that cancer takes upon itself. It's not inherited, and it does it for a survival advantage. I think we're still always going to target that, but understand that is targeting all of these hallmarks of cancer, metabolic, replicative immortality. But really, if we can tap into the immune system, and there's newer testing that is now clinically available, where we can actually tap into what is the immune environment like. And people go, well, why is the immune system becoming so front and center? Because when you look at history, as the war on cancer took off, immunotherapy basically took the opposite turn, because it was competitive in the marketplace to chemotherapy. And as chemotherapy hit it, all the work that William Coley and others were doing in immunotherapy basically had to be squashed. Now everything's about the immune system, though we can never say everything is always about the immune system, because the immune system is the body's defense to protect the body against all enemies of foreign and domestic. So here what we can do is we can actually now discern what's the immune cells that are in the tumor microenvironment. What are the immune signaling, and how is it controlling those immune cells? Are the immune cells pro-tumor? Are they anti-tumor? And so we're moving far beyond the mutation idea, though we still have to incorporate that. But what's going to happen, it's going to become a smaller and smaller part of what we target, but it will always be there. More and more, we're moving into these other areas that really empower the immune system. I believe that's where it is now, and that's where it's going to be in the future, other than if we have time, or we could talk about another podcast where we actually just transform cells outright.
Oh, that would be amazing to talk about. With all of this knowledge and new research coming out, and it'll continue to advance, and I'm sure therapeutics will also continue to advance with the new knowledge, and hopefully achieve better, superior outcomes, not just survivorship, but also outcomes that reduce the risk for future cancers. Because currently, with the current treatment, chemotherapy increases the risk for secondary cancers later in life. And you wrote an incredible book, Breaking the Cancer Code: 7 Next Gen Integrative Oncology Therapies, in which you go through the approaches that are options that are very different from just the conventional surgery, chemotherapy, radiation therapy. And I'd love for you to talk about some of those, and how this approach, you think, provides that treatment that patients need without the conventional, or in combination. I'm wondering if it's instead of, in combination with conventional. How do you approach this from an integrative perspective?
Yeah, I think what drives this change is where we're thinking about how to approach the cancer, strategy at large. So the way cancer has been, since really World War II, but Nixon declaring war, it's been, okay, just bomb the battlefield, right? Let's hope the body survives as we target the tumor for destruction. And if it does, then we'll start the healing process, help you recover, and then you can get back to living. That's a strategy that now patients really, for the most part, don't accept. They said, look, I'm not going to sacrifice my quality of life for you to bomb my body. And you mentioned that chemotherapy causes second cancers. It causes metastasis, period. End of story, end of discussion. The research on that is overwhelming. Yet we need a pivot, and that pivot is born by two things. I think you have to look at Hanahan and Weiberg with their Sentinel paper in 2000, describing the first 6 hallmarks of cancer. They then added to that in 2011 and 2022, where they're looking at these precise characteristic pathways and signalings and behaviors that are broadly extrapolated to all cancer types. It's not just a name now: breast cancer, prostate cancer. It's now more what pathways, what signaling, what immune disruption, what are these cancers doing, and they're uniform across it. And when we look at the FDA says, oh, this drug is indicated for this PD-L1, the soluble PD-L1, or the extravesical PD-L1s that are circulating. But guess what? That doesn't just happen in one cancer type. So that shows you how the regulation capacity is still in the Stone Age. But then it also is born out of this arena of what's called multiomics. And so this is where we get genomics, epigenomics, transcriptomics, proteomics, immunomodulomics, microbiomics, hormonomics, and all these whatever omics, which are fields of study that are showing us the precise nature of what cancer is doing, and thus allows us to precisely target cancer. What I say is the right treatment for the right patient at the right time. So there's many different capacities of where I believe cancer is going and where it is actually right now. Repurposed medications, I'll just touch on that real quick, because repurposed medications in oncology is a relatively new one. It was actually originally described in 2004 as repositioning, which obviously that doesn't have the ring, but really in 2014 with the Redo project, that's really where it took off, where repurposed medications are medications that really have a long safety track record. And there's indication and research that shows they could be repurposed for a pathway that could target cancer. I mean, metformin is probably the most studied. In patients' minds today in the public consciousness, ivermectin is front and center. And people say, well, let's use ivermectin in cancer. And I would say, why do we want to use ivermectin in cancer? And how is it best indicated to help these patients? And so we can use repurposed medications, but we must understand we can't use them just like oncology has used chemotherapy, where they just throw it on the wall and hope it sticks. We must use these in precise, indicated manner. So I actually see the integrative oncology space making some of the same mistakes that conventional oncology. But I love repurposed medications in oncology. Nutrition, we can never forget about nutrition. Take immunotherapy, for example. Fiber, research clearly tells us you increase fiber to 30 to 50 grams per day, you're going to increase the immunotherapy response. Why is every oncologist in this world not prescribing fiber as a part of a therapeutic strategy if they're undergoing immunotherapy? Beyond the scope to me, but fecal transplantation, this is where I get super excited, and people are probably freaking out. Fecal transplantation, what does that sound like? And I actually, when I'm on stage, I usually, when I mention that and I talk about it, is I always tell people, I'd love to see the cartoon bubbles above your head as I mention this, because I have no idea, and it would be hilarious to see what you're envisioning. What this is basically like we talk about a heart transplant or like we talk about a lung transplant, we're transplanting gut microbes and the gut metabolites therein from one host, donor, to a recipient. Okay. Now, there's a standardized way to do it. There's actually an FDA approved product here in the US, but it alters that microbiome. It engrafts and it changes the immune system. Now, why is that important? Well, we know an altered gut microbiome is critical and intimate to the carcinogenic process, especially colorectal cancer, pancreatic cancer. We're now even starting to understand that in some cancer types, maybe all, we don't know, there is a tumor microbiome. So there's actually bacteria, very small levels, but still enough there, and that alters the cancer's receptibility to treatment. Wow. So we could actually modulate the tumor microbiome through the fecal transplant and altering the gut microbiome. But it's not just the bacteria, it's those metabolites as well, boosting the immune system. I mention this a lot because it shows the profound impact of what we've been doing in the industrialized agriculture, is basically depleting the soil of its nutrients, what farmers in regenerative space call dirt, and that's transferring to an altered gut microbiome. And they provided a 2-year update on what's called My Baby Biome research, where they're following these children, which were recruited at 3 to 7 months, out to 7 years. And what they found is that 25% of these children had no bifidobacterium in their gut microbiome. None. Wow. Complete extinction of a species that is critical, imperative to immune priming. So these children are set for a lifestyle, if there's no intervention, of compromised immune surveillance. Translate, disease. That's where they're headed, without a doubt. So not only do we have a chance to impact immunotherapy, we have a chance to impact and prevent disease. Because right now, where fecal transplant is it's very much early in its infancy, where we can actually take a patient that has not responded to immunotherapy, particularly here we're talking about the conventional immune checkpoint inhibiting therapy, and then take a donor from one who did, transfer that, and then that patient will now respond. That patient will now respond. So, but we have to understand immunotherapy is not just confined to immune checkpoints, okay? They're confined to anything that's modulating the immune system. Diet does that. Fasting does that. Exercise does that. Mistletoe does that. So I want people to think beyond immunotherapy as just a drug. It's anything that's modulating or improving the immune response. So I love fecal transplant, but then also things like the targeted osmotic lytic therapy, which is very much in its early phase as well, where hereby you're using the process of osmosis. And what that means is that's where water basically goes from low solute concentration to high solute concentration across a semi-permeable membrane. And so it creates this homeostasis of fluid transfer. And so here we can actually use this against the cancer, because as cancer is progressing in later stages and more aggressive types of cancer, it overexpresses these voltage-gated sodium channels. And we can use that against the cancer and then block it and then cause them to burst. And guess what? We're using a repurposed medication there to help block it. And then with the targeted osmotic lytic therapy, we cause them to burst. So it's a combination of a new innovative therapeutic TOL and repurposed medication in oncology here, primarily using digoxin. And one that we're now just starting to get involved with which is called therapeutic plasma exchange, which is just stupid crazy, because we now know, for example, when we look at microplastics in the reproductive organs and the contribution to cancer there, the hormone disruption, if you're just looking at it from a wellness perspective, organochlorines, organophosphates, and then let's take that Sentinel-1 glyphosate. We know that these chemicals in the environment, in the industrialized agriculture are propagating some of the environment that propagates disease, and here particularly cancer. What if we could actually filter them out?
Yeah.
We can. And therapeutic plasma exchange allows us to do that. What if we could actually add this in, filter out, say, for example, say there's soluble PD-L1, which are immune checkpoints, circulating around that create immune suppression, particularly among T cells, or extravascular PD-L1s, which these are immune checkpoints that basically what happens is they suppress T cell activity, which is a very important immune cell to target cancer. What if we could filter these out right before we give immunotherapy? There's actually been a phase 1 study in melanoma patients that actually shows by doing that, you can increase that response rate to over 67% in patients that weren't responding. So this is precise nature, but it's not drugs. We're modulating and modifying the immune system. You might call some of these therapies natural, holistic, integrative. From the conventional mindset, they're not waging war. What they're doing is they're engaging the immune system. And of course, what we do at the Williams Cancer Institute is intratumoral ablation, intratumoral immunotherapy. Because this novel concept that cancer is a solid ball of cells isolated from the rest of the body is now no longer really born in the science. It integrates with the body within this tumor microenvironment. And basically what research shows is about 1% of all systemic therapy given IV reaches the tumor or tumors. And if you have a large tumor burden, whether that's one big tumor or a bunch of small ones, it's probably even less than that. That's what the literature suggests. So in that problem, we just go right to the tumor. Actually, a needle in the tumor, we destroy part of the tumor. The question then should come, why part of the tumor? Well, because research shows that that is required to activate engaging the immune system. Then we create dead cancer cells that create tumor-associated antigens, but particularly tumor-specific antigens. But that's not enough, because now we have a problem where 25% of the tumor microenvironment is not going to have immune cells there to see those antigens, dead pieces of cancer cells. That's called an immune desert. And 50% above that 25% are immune maladaptive. So now what we have to do is we inject intratumoral immunotherapeutics, not blindly, but to actually activate prime T cells, reverse T cell exhaustion, recruit natural killer cells, block immunosuppressive cells like myeloid-derived suppressing cells and Tregs and their signals, and actually allow the immune system to be recruited, trained against the tumor antigens, target the tumor, and then send immune cells out to go find those distant, untreated tumors. That's called the abscopal effect, to create a sustained, durable, systemic immune response. So in a way, and I don't like the word vaccination, because the word vaccination just really means that which pertains to a cow. And so obviously we're not talking about that. But what they did there is they used cowpox to inoculate patients for smallpox. But here it's inoculation. We're inoculating the immune system. We're training it. We're training it. And then we let the immune system do what it's designed to do, John, and we let it do the dirty work. And guess what? When the immune system does that, it targets the tumor. It doesn't target the healthy cells.
Yeah.
So that's just like natural therapeutics, which have the ability to differentiate that which they're targeting. They'll target the abnormal cells, but they don't target the healthy. They can actually protect them. And that's what we're doing by engaging the immune system. So I went kind of around the bend and back again and tried to touch on a bunch of different points in there. But the future of cancer care, John, is so incredibly exciting. One challenge I say that we've got there is the regulation capacity not keeping up. So we're at Williams Cancer Institute, we're actually trying to innovate there as well. And it was really interesting. We did an X Spaces Live yesterday, and we actually had a question that says, why don't we just burn the whole system down? And I was jogging yesterday evening after that, and I thought, burn the whole system down? Because I responded to it, and I said, we can't burn the whole system down, because then all we'll have is ashes and basically just smoke, and patients will have nothing. What we need to do is change the system from within. And I believe we can do that. I mean, more than ever today. I mean, look at RFK, okay? That guy is doing more, I think, to put power back in the hands of patients than anybody in that position of Secretary of Health and Human Services. So he needs help, he needs allies, okay? I'll stand up and say, here I am, send me. And so we stand in there because I believe it's going to bring forth the future of cancer care, but it's going to empower patients. And honestly, it's going to restore the patient-doctor relationship,
So
which
you're
is critical.
it is critical, and you are research driven, data driven. You look at the underlying physiology, biochemistry, the omics. When you put these therapies into practice and you're doing multiple modalities, multiple approaches, I don't know if that's what you refer to, that you talk about in your book as precision therapy stacking. That's what I think of. But what kind of outcomes are you getting?
Yeah, so it's really fascinating because 92% of our patients, give or take a percent, are stage 4 recurrent, which they're at that point where they either look for clinical trials or they look for palliative care or they look for nothing. Okay, so basically it's patients looking for the Hail Mary pass. And that is not a great position to be in from any physician perspective at all. They're compromised at large. Their body is extremely compromised. They're typically cachectic, which is they're wasting away of muscle. It's a difficult spot to be in. But what we're able to do there is in many patients, not all, because cancer is a beast. It is a beast. We have to be honest there. We can bring people back from that and actually allow them to achieve remission, but never compromise their quality of life. We've had patients with stage 4 pancreatic, colorectal, hepatocellular primary liver cancer, neuroendocrine tumors, breast cancer, stage 4, go into remission, some with as little as 3 treatments, 3 to 4 treatments, and be in remission now for years to decades.
Wow.
And what's great about it is they don't have to hope they survive. They don't have to then work to recover and then start to live. They actually live as they start treatment, which, what's the purpose of treating cancer? Well, it's so that people can live. Well, why wait? And so we believe that engaging the immune system in this precision stacking, you're correct, the right treatment for the right patient, the right combination at the right time, it allows people to not put a pause on the live button, but actually begin it today as we do that. And so, we have tremendous results. We're even innovating in that, John, because, just this week, 2 patients, we did biopsy and treat at the same time. Now, what's that mean? Well, what if a woman has a breast mass, okay, and she gets a biopsy? Typically, it's 30 plus days until any type of treatment is initiated. Well, research tells us that delay is going to be incredibly problematic for long-term outcomes and metastasis. Why can't we biopsy and treat simultaneously? Because if it's like a 1 centimeter tumor, so for example, this 2 patients, one was actually a recurrent melanoma. It very much looked like metastatic melanoma, left axillary lymph node, but it hadn't been biopsied. And the original diagnosis was years ago. So we said, well, let's biopsy and then let's treat it. So when I was seeing this patient post-procedure, of course, the initial pathological assessment was, yes, this is metastatic malignant melanoma. And I told the patient, I said, Stephen, I said, the pathology, the final pathology will take about 7 days, 10 days, we'll know. And he said to me, he said, but I already got treatment, right? I said, you did. And it's not treatment that was just arbitrary. It was treatment because we knew that it was almost invariably metastatic malignant melanoma. And so we understand a lot about the immune system dysfunction there. And so we brought that to bear with certain like CD40 antagonists, et cetera, to really bring the immune system in an anti-tumor way for metastatic melanoma. The other one was a breast cancer patient, but we've done this in basically treatment-naive breast cancer patients. I mean, look at ductal carcinoma in situ in breast cancer, really kind of a, not a cancer per se, invasive-wise, but women are being recommended bilateral mastectomies for that. What if we biopsy and then treat simultaneously? Those patients are done. They're done. And we ablate it and so then they preserve their breast. And
Yeah,
it's
it makes me
basically kind of a drive-through. I hate to use that term, but it's kind of a drive-through treatment strategy that allows them to immediately get right back to their life.
Yeah. It makes me think of the Mohs procedure in dermatology, where they're biopsying and sending it off and then treating there. I mean, they're looking for, surgically excise the lesion and getting clean edges, but they're doing it, while looking at the pathology, while looking and ensuring that they've got it all. And I don't know if that's an
It's
accurate
close.
analogy, but yeah.
I think it's close, and I think it's a good one. But there's a significant yet subtle difference. With the Mohs procedure, is they're removing all of it, as you mentioned, the clear margins. Our purpose here is just to confirm the presence of the disease. Okay, number one. But number two, it's to then ablate it in part with our preference of choice right now is pulse electric field therapy, which is nanopulses of high voltage energy. So it goes through a needle directly into the tumor. And not only does it basically create these tumor antigens because it destroys them, it breaks up this fibrous uh, tumor microenvironment matrix that rebuffs the immune system. And so we break that up, so that's going to allow immune infiltration. Then we basically inject intratumoral immunotherapeutics, which could be things such as microdose chemo, microdose immunotherapy, could be nucleic acid sequences, could be things such as pattern recognition receptor agonists, which are preserved things like toll-like receptors, here, toll-like receptor type 9, CPG. We can even inject oncolytic viruses, and then things such as natural, vitamin C, artesunate, mistletoe, all of these are therapeutics that we do and can use to recruit and activate the immune system. But it's different because in the Mohs procedure, they're cutting all of it out.
Right.
No, we want to engage the immune system. See, that's still back to that surgical mindset, cut it all out. Well, research actually says if we ablate a whole tumor, now we can't activate the immune system because there's nothing to activate against. And with patients that get a Mohs procedure, what you invariably see is a lot of them, not all of them, but they'll get recurrent Mohs procedures. And it's because you've not engaged the immune system. You engage the immune system, it's going to do the long leg work to make sure it never comes back, whether locally or systemically.
As you were talking earlier, I had an image of my mind, and I'm wondering if this is accurate, even conceptually. That if there are tumors in different parts of the body, and you treat one, is there inter-tumor communication that exists so that if you treat one, there's some communication pathway where you can also get benefits at a site in the body that's not exactly where you just treated, but that treatment can kind of spread in some way? And I don't know if that's just through the immune system priming. You mentioned tumor cells that are not expressing receptors for the immune cell to be able to recognize them. Does treating one area change the signature, the biochemistry? I don't even know the terminology for it. I'm not in your field, but of similar tumors elsewhere in the body to make them more sensitive to the therapeutics?
Yeah, there's really two sides to that coin. One is when we engage the immune system in training against the cancer, it'll send immune cells out to find those cells. Okay, so that's not necessarily the tumor cells communicating, but it's the immune system basically targeting the similar tumor cells, though at different locations. So I'd say that's one side, and that's what we do. That's called the abscopal effect, which is two words: abscopus, meaning away from target. By the way, first described by Dr. R.H. Moll in 1953. So
Wow.
we're talking about, 75 years almost ago. Not anything new. The problem has being able to create consistent, sustainable abscopal effect. Now, there is this concept within cancer that we're understanding now that the way cancer metastasizes is very different. In fact, in many cases, metastatic or micrometastatic dormant latent cells are already there, but there's a dominant tumor that's creating these suppressive signals that keep that dormant latent metastatic site not active. So then what happens is you go in and maybe you radiate and destroy a whole tumor, a dominant tumor, or you surgically resect it. And then what happens is that plus the immunosuppression associated with those procedures allows that dormant latent immune cancer cells, actually to come out of latency and actually start to grow. So, and this is how you can see distant metastatic sites show up so incredibly quickly after, for example, a surgical resection of a primary dominant tumor. So our understanding of the process of how even metastasis occurs is different. And the problem is we have, doctors aren't keeping up with the literature. It's been probably 15 years that I referenced an internal medicine article back from 2001 where they talked about physicians practicing at a level that was 17 years behind the current published. Right now we have a problem where AI is accelerating this so fast, and we're accelerating so fast that doctors are falling further and further behind the science and where it's at. But here's the problem. It's there. Patients have access to it. But not only is our doctors falling behind, patients are accelerating ahead, but the regulatory capacity is falling behind. That's why we have to work within the system and work there as well. And that's why what we do at Williams Cancer Institute, we're innovating in the research base. So not only are we doing phase 1 studies in Mexico, we're doing phase 2 in United States where things get fast-tracked out of another country, which is more open in market to innovation, and then we fast-track it into the United States. We're even innovating in how therapeutics are being approved by the FDA. Our phase 2 metastatic castrate-resistant prostate cancer is the first time that 4 therapeutics were used together and approved as a indication or being approved for study. It's not yet approved by the FDA, but our injection into the prostate tumor is 4 drugs, 4 therapeutics.
Wow.
Now, we want natural as well, okay? But these are 4 therapeutics, combining that with cryoablation. That's the first time that's ever happened, because we can't look at cancer and go, oh, it's this one thing. That's ridiculous. That is oversimplifying the reality of the situation right into falsehood. It's called the concept there is simplism, where we try to simplify something to understand it, but we do so right into inaccuracy. Yeah. And so we're trying to engage as much of those abnormal pathways, hallmarks of cancer, if you will, simultaneously. And so we're trying to really innovate on every level possible.
You talked about the regulatory environment being behind the science, slower, hasn't caught up to it yet. What about the insurance environment for patients having access to this sort of thing?
Yeah, because the FDA could approve something, but that's irregardless whether insurance will cover it or not.
Yeah.
I think the problem that we have right now is we have a problem that I call advocacy confusion, which is basically we as physicians, you and I, we are advocates for patients only, nobody else, no regulatory body, no state regulatory board, no insurance company, etc. We should be advocates for patients alone. But what's happened is, if you look at it as a quote unquote bed, okay, you have doctors thrown out on one side and you have patients thrown out on the other in the bed on the floor, and everybody else is in the bed, okay? They're having, for lack of a better term, an incredible orgy on the profits that ensue. And what's left out is the patient. And then what's left out in many ways is the doctor's ability to help the patients. Now, I do believe that some regulation is necessary, because otherwise it would just be chaos. But getting to health insurance, I think we need a pivot on health insurance to more of what we have with auto and what we have with house, where it's catastrophic, major disease type thing. What if we had insurance every time we went to fill up our gas, and so we had to file it through our insurance? It would be astronomically expensive. Every time we went and changed the oil, it would be astronomically expensive. Yet because it's direct consumer to that which provides the service, the cost is controlled, because the market is demanded by the consumer. Here, the consumer is the patient. And so we put the power back in the patient. The patient can make the decision, and if they're using their own dollars, guess what? They're going to drive costs down. That has been borne out repetitively throughout economics. But right now what we have is middle people that are jacking up the cost because they're controlling access. When I get off of this podcast, John, I'm going to get on some phone calls to try to get prior authorizations for some therapeutics for patients. I have been trying to get one drug approved for a patient for 4 freaking weeks.
Wow.
Have I talked to a doctor? One time. What have I done? I've gone from a specialty pharmacy back to the insurance company, back to the specialty pharmacy, back to the insurance company, and go nowhere. Now, I don't believe that's by chance. It's designed to, I think,
It's their
basically
model.
create a bottleneck so that coverage just doesn't happen and I give up,
Yep.
okay? Or patient gives up. I think insurance has a purpose, but I think how it's being employed right now is wrong. It's completely wrong. They dictate coverage, meaning they dictate what Medicare and Medicaid cover, and they dictate and restrict access to
Yep.
patients. Let me tell you what, there should be no insurance company that's restricting access. Because let me tell you what, my experience with insurance is that, yes, doctors are behind. Insurance doesn't even try to keep up. They don't even try to keep up. There's no incentive for them to keep up. And so we've got to rethink how this model works, not destroy it, not burn it down, but return all players to the purpose of serving the patient. Government, regulatory bodies, insurance, doctors, medicine at large. And I think by doing that, we can.
Yeah, and I love that you say that, and you've got such a strong moral compass, and you've haven't deviated. Many doctors I know who have gone through, clinical practice, their residency, they end up in a institutional setting where they're frankly exhausted, and they've got bills to pay and student loans to pay, and not that they are bad people, but there are choices that everybody makes in their lives of how much energy of their life are they going to dedicate. They have families, they have bills to pay, to chart a different path, which is not the easy path. And so I'm just so incredibly grateful that our paths have crossed, and I've got to share your information and you with my audience, because it gives not only an additional way for people to think about this approach, but it gives an option. It gives them access to somebody who is on the cutting edge of the research and development, not just theory, not just bench work in a lab, but working with patients and improving lives and improving outcomes and saving lives, because you recognized that the system is broken. The system is not serving the patients, and you are going to go and chart a path that is through the lens of what the research shows works, how you can create systems and customized approaches for the individual to treat the person and not treat the lab result, or the number on a test, or just doing what the insurance company says is the right thing to do, because they are not the physician. They are not the ones with the knowledge, experience, and understanding. You are with the patient. And so it is such an honor to be able to speak with you.
Well, John, thank you. But I don't, I personally don't look at it as quite that extraordinary. I think it's just understanding what it means to be a physician. It's that simple. Serve the patient, give them hope, heal them, teach them, empower them through trust, speak truth, and then build a legacy. I think those concepts are what make up a physician. And if we do that, then guess what? We're going to do the right thing, even if it's the hard thing, because it's the purpose of which I believe it's an incredible profession. It's an honorable profession to serve patients. We've got off track there because we've forgotten those principles. And I think by returning those principles, doing the right thing becomes the easy thing, even if it's hard.
I love that. I love that. How can people find out more about you, your work, connect with your resources that you've developed?
Wow, I'm kind of all over the place because I want to empower patients, innovate, elevate, empower. So basically, you can find me. I work with the Williams Cancer Institute. Dr. Williams and I went to medical school together, so we work together there in innovation. You can also find me at pre-scribed.com. So that's prescribed, but there's a dash in there. That's where I do my blogging. That's where I do my podcasting as well. And I talk about all variety of topics, John, some that are cancer and some that are maybe not cancer. You find me, of course, my largest following is at Instagram, and they were shadow banning me for a while. That seems to come off, but dr.goodyear. We're on X. Dr. Williams and I are doing X Spaces Live. We'll be expanding on that as well. And then you can find me on Facebook, LinkedIn. You can find me pretty much everywhere. So just look. And what I can do too, John, is send you a QR code that will provide an easy link. You could put it in the show notes if you so chose, where patients can just take a photo of it, and then they can find all the different access points.
Yeah, please do that. That's a great idea. We will have the links in the show notes, but if you send that QR code, we'll make sure to add that as well. Thank you so much for your time. Any last thoughts you'd like to share with the listeners?
Yeah, so Dr. Williams and I have a new book that'll be coming out sometime after the first of the year. When it gets through the final editing process, goodness gracious, and it's basically we're proposing where the future of cancer care is really going, and that aging and cancer are not different. They're one and the same. And so by targeting cancer, we can actually heal the body. And so we believe it's a new paradigm in cancer care, but it's using those hallmarks and it's being precise in nature. And that's why we believe, because we see it in our patients, where you can actually transform cells, you can actually heal cells as you target tumor for destruction.
Amazing.
So that's going to be coming after the first year. Don't have a launch date. Actually, don't have a title yet.
That was going to
the
be
book
my
is
question.
done. It's in the final editing phases ×2, so it should be coming soon. And you'll find out information on that, of course, on all those different access points.
Yeah. And do you have a newsletter as well that people can sign up for?
Yeah, so they can sign up when they go to pre-scribe.com. They can find up to all our newsletter information, and we have basically exclusive content that we generate to give you access to behind the scenes, and maybe when I lecture, you get access to that lecture, whereas others don't. So we are creating access points that patients will have exclusive access to there. We just want to give patients the ability to steer their care.
Thank you. Keep up the good work, the amazing work. Really appreciated the time we spent together today.
Yep.
And thank you so much.
And John, you as well. Thank you for it takes a lot of courage to speak out, right? And so I always like to encourage those that do that. And so thank you for what you've done, both in your books, your writings, and your company, and in the podcast.
Thank you.